Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the water balance of fluid and electrolyte balance. Daily water balance of a healthy adult is water from the beverages accounts to be 1200 ml, water from solid food is 1000 ml and water from oxidation is 300 ml. Output accounts for its urine output 1500 ml. Insensible loss of skin and lungs is 900 ml and feces is 100 ml. The intake is derived from two sources. Exogenous water is drunk or ingested in solid foods. 2 to 3 liters per 24 hours, of which nearly half is from solid food. The water requirement of the infants and children is greater than those of adults because of a larger surface area per unit of body weight, greater metabolic activity due to growth, poor concentration ability of the immature kidney of neonates. Endogenous water is released during oxidation of indigested food and amount is less than 500 ml per 24 hours. During starvation, this amount is supplemented by water released from breakdown of body tissues. Output. Water is lost from body by 4 ways. Through lungs, about 400 ml of water is lost in expired air in 24 hours. In a dry atmosphere and when the respiratory rate is increased, the rate is greater. By skin. When the body is overheated, there is visible perspiration, but throughout life, invisible perspiration is always preceding. In temperate climate, average loss is about 600 to 1000 ml in 24 hours. Feces. About 60 to 150 ml of water are lost by feces daily. Urine. The output of urine is under the control of secretion of the posterior lobe of pituitary gland, antidiuretic hormone, which controls the tonicity of the body fluids. Water depletion. Pure water depletion apart from the concomitant electrolyte depletion which follows diarrhea or vomiting is usually due to diminished intake. The causes may be weakness, exhaustion, mental changes and cerebrovascular states. Because intake is restricted after gastrointestinal operations or inability to swallow, as in painful conditions of mouth or throat or esophagus obstruction. The main symptom is the intense thirst and the leading sign is the oliguria. Treatment. The intake of water must be increased. If swallowing is possible, much depends upon the nursing people ensuring a regular half or hourly intake. Intravenous 5% dextrose or dextrose saline is given if swallowing is not possible. Careful charting of intake and output is essential. A diuresis signals that enough has been given and thereafter care must be taken not to overload and cause water intoxication. Thirst. The seat of osmoreceptors, that is drinking center, is in the supraoptic nucleus of the anterior hypothalamus. Thirst is most intense after 6 hours after operation and lasts for 48 hours or more. This period corresponds to the rapid loss of potassium from the cells of the body. If necessary, the urge to satisfy thirst can be assuaged by sham drinking contact of water with the pharynx by washing out the mouth with ice cold water. Water intoxication. It can occur with of a loss of sodium, especially if excessive intake of water is rapid, is more likely to supervene with impaired renal function, leads to swallowing of diuresis, slowing of diuresis. There is always a danger of water intoxication when there is failure to keep accurate intake and output chart. Failure to add up the 24-hourly total chart as well. Failure to be aware of water intoxication can actually occur. It is likely when 5% dextrose solution is administered intravenously. When fluid therapy is undertaken by administration of tap water per rectum, following rectocolonic washouts of plain water or sodium-free solutions, especially in children. Clinical features. The clinical features include drowsiness, apathy, weakness, excitement and delirium. Lastly, convulsions and coma. The patient is pale and cold, bathed with sweat, and the patient appears to be in shock, which is not correct as the blood pressure is not low and the pulse is not rapid. Nausea and vomiting of clear fluid is common, and the patient usually passes a considerable amount of dilute urine. Diagnosis. Diagnosis is confirmed biochemically by finding a reduced plasma sodium volume. Treatment. The intake of water being stopped, and best course is masterly inactivity. If after several days the patient is still stuporous due to no renal activity, it is permissible to inject very slowly, not more than 200 ml of hypertonic 5.85% of saline solution. Intravenously, if there is improvement and diuresis begins, the injection should be stopped to prevent circulatory failure or cardiac arrest. That's all about the water balance, and in the next video I will discuss about some other disease. Thank you.